Hello, this is a talk about current understandings of food allergy. My name is Dr. Jennifer Lightdale. I am Division Chief of Pediatric Gastroenterology and Nutrition at UMass Memorial Children's Medical Center and a Professor of Pediatrics at the University of Massachusetts Medical School in Worcester, Massachusetts. The learning objectives of this talk are to illustrate our current understanding of the immunologic pathway behind food allergy. We will also aim to address common misconceptions about development of food allergies, discuss optimal evidence-based approaches to diagnosis and management of patients with food allergies, and review new recommendations and guidelines around their prevention. As background and somewhat common knowledge, I think it is reasonable to state that food allergies have become very common in both pediatric and adult patients. It is currently estimated that about 6 to 8% of children and 11% of adults have food allergies, and there has been rapidly increasing prevalence across all age groups. Risk factors for food allergies are presumed to be epigenetic, as well as environmental, cultural, and behavioral. There are numerous common misconceptions about food allergies that are important for clinicians to recognize, as not understanding the pathophysiology for food allergy may actually exacerbate patient risks of developing and or having adverse effects from food allergies, and even unnecessarily and negatively impact patients' quality of life. As a first tenet of understanding food allergy, it is helpful to remember that not all food intolerances are allergies. And actually, if you look at adverse reactions to food, you can classify them as toxic and non-toxic. Toxic reactions are essentially food poisoning due to toxins in foods. Non-toxic reactions can be non-immune mediated and more related to enzyme deficiencies, pharmacologic reactions to food components, and assorted other reasons that generally involve neurologic effects. Non-toxic reactions, though, can also be immune-mediated, meaning they involve the immune system. Under this umbrella of food intolerances, the reactions are either IgE-mediated or non-IgE-mediated. IgE-mediated reactions are what are also known as type 1 immediate hypersensitivity. These allergies are quick in onset after exposure to the food allergen, often occurring within minutes and certainly within an hour. The reactions themselves can be systemic and involve anaphylaxis, or are often more mild, such as hives. There is a well-defined mechanism for IgE-mediated allergy, which I will walk us through more in a minute, and they are easy to diagnose because they happen quickly after exposure to the food that is triggering them. So you're having the food, and minutes later you're having the reaction. Sort of obvious to see that this is happening. There are also a number of validated tests that can be used to diagnose IgE allergy, many of which involve actually measuring IgE levels. In contrast, non-IgE-mediated allergy, or types 2, 3, and 4 delayed hypersensitivity, have, as noted, a delayed onset after the exposure to the trigger food, and this is at least a few hours and can be as long as 12 to 24 hours. The reactions are often not systemic and generally involve non-specific symptoms, including eczema and even gastroesophageal reflux. So because there's such a delay between the trigger food and then these bothersome non-specific symptoms, it can be hard to link the food to the symptoms. The mechanism of non-IgE allergy is less defined, and the delay, as I said, between the exposure and the reaction make them hard to identify. And all this together makes them very hard to diagnose. Furthermore, because there is no IgE to measure in types 2, 3, and 4 delayed hypersensitivity, there's actually no validated tests currently to confirm them. Whether the reaction involves IgE or not, if the immune system is involved and the reaction is triggered by exposure to the food, we consider it to be allergy related. So all food allergy is immune-mediated and involves allergic sensitization of the immune system. Food allergy most often reflects 1 or 3 different types of immune system reactions. so they can be IgE, non-IgE, or mixed IgE and non-IgE. Also relevant to this conversation about food allergy is the recognition that 9 foods account for most food allergies worldwide, and these are milk, soy, egg, wheat, peanuts, tree nuts, fish, shellfish, and sesame. So this is my favorite slide to explain IgE and non-IgE-mediated allergy. But admittedly, it often overwhelms people, so I'm going to take us through it very slowly. First, I'm going to talk through IgE-mediated allergy, which in this slide is illustrated by imagining milk protein, the little green dots, which is certainly one of the leading triggers for food allergy worldwide. In IgE-mediated milk allergy, an undifferentiated T cell, or what is known as an antigen-presenting cell, sees the milk protein and decides that it is a problem antigen. It reacts by differentiating into a Th2 cell, which signals to a B cell to make IgE specific to the milk protein. The milk-specific IgE, which are the little Y-shaped proteins here, then cross-link to both the milk and to what are called mast cells, which are filled with histamine. When enough IgE cross-links between milk and the mast cell will actually burst apart and let out their histamine, which can cause a hive. And then if enough mast cells can burst apart and let out enough histamine, you can have a systemic reaction, which is anaphylaxis. This all happens very quickly, within minutes, and is very IgE specific to milk. So the antigen-presenting cell sees the milk, and within minutes, you have a histamine hive. And this is why antihistamine works for IgE-mediated allergies. Okay, let's go to non-IgE-mediated allergy, which actually, amazingly, involves the same antigen-presenting cell seeing the milk. But this time, it differentiates into a Th1 cell, which can induce a number of reactions. Here you see it calling macrophages to the scene. A few things to note here. There is no B cell involvement, and you see there is no IgE being made. Also, can help to think of the macrophages as like very slow-moving jellyfish-like cells that actually take hours for enough of them to amass and create a reaction. So you can't measure IgE to know that this reaction has occurred, and the reactions may take hours to really cause a problem. There's also no histamine, so this is why antihistamine won't work here. A few other things to know include the fact that the decision of the antigen-presenting cell to react and the way it seems to react is actually mediated by a different cell called a regulatory T cell, which I fondly think of as a policeman. The Treg actually has ability to tell the antigen-presenting cell or the Th0 cell how to react. It can also tell it to remain calm, as all the APC is seeing here is milk. It's not a microbe, it's just food, and that's actually benign. So ideally, the antigen-presenting cell doesn't go in either direction, Th1 or Th2. I think when you look at the whole picture this way, you can see why some children and adults have mixed IgE and non-IgE food allergies, as sometimes the APC differentiates towards the Th2, and sometimes it differentiates into a Th1 non-IgE pathway. Finally, it is important to know that the microbiome, or the trillions of microbes that live in your gut, can also determine whether and how the antigen-presenting cells react. I do discuss the gut microbiome and its relationship to this immune system in depth in a different webinar if you want to know more. At the root of all of this is the fact that the immune system is having an abnormal and unnecessary reaction to food proteins in the gut lumen. And we do know that the food proteins or antigens are triggering the immune system through the gut lining or the epithelium. So there are a number of misconceptions about food allergy regarding their prevention, diagnosis, management, and population burden that can be reflected in variations in knowledge, attitudes, and beliefs among clinicians. They also likely reflect differences in education, as primary care versus various specialty physicians may have different approaches to considering allergy, and this can affect the practice of nutrition experts, not to mention how we all counsel patients. Unfortunately, these misconceptions can also lead to conflicting advice, including around dietary guidance, exposure protocols, and in our recommendations regarding allergen avoidance. The implications of these misconceptions are myriad and likely reflect the fact that many previously held assumptions about food allergy are now known to be incorrect. Important examples include the reality that exposure to, not avoidance of, potential allergens is important to both preventing allergy and inducing tolerance. In fact, avoiding allergens can be a risk factor for developing the very food you are worrying about being allergic to. This concept is particularly a concern around children who have IgE allergies to peanuts. Contrary to popular belief, children who are allergic to peanuts are not allergic to all tree nuts and should not empirically avoid nuts so as not to develop unnecessary food allergies. As a second example, it is important to recognize that children with severe IgE or non-IgE egg allergies may safely receive influenza vaccine. And actually unnecessarily avoiding flu vaccines is a big risk factor for morbidity and mortality from the flu. So even if you have egg allergy, we want you to get flu vaccine. All told, it's more important than ever to correct misconceptions and clarify optimal approach to food allergies, as this is the key to ensuring optimal public health outcomes. Furthermore, it is especially important to correct misconceptions about food allergy, as falsely elevating these have been shown to amplify patient concerns. For example, not all infants with eczema will develop food allergy. Instead, although there may be some higher risk in early onset eczema, for instance, eczema that develops in infants less than 2 years of age, and in infants with moderate to severe eczema, the bottom line is that most infants with eczema are not at risk for food allergy. So posing this concern for parents of infants with eczema only leads to unnecessary parental concern. In another misconception that can make patients worried, it is not clear at all that larger skin prick tests, or a big reaction to the skin prick tests, and or higher levels of food-specific IgE testing, so the higher the number on your IgE test, is a predictor for severity of food allergy. Instead, it is important to know that currently available testing modalities do not reliably predict allergy severity or infer safety. In fact, anaphylaxis and other serious systemic reactions, such as acute food protein-induced enterocolitis syndrome, which is non-IgE-mediated, can be encountered in patients with testing that shows either high, low, or even no level IgE. Another big misconception that providers must correct is around timing of food introduction, as there is now great evidence that delayed food introduction does not prevent allergies. Of course, this misconception is understandable, as feeding guidelines for infants have significantly changed in the past decade, and previous guidance, even as recently as in the past decade, has indeed called for delayed introduction of highly allergenic foods. Nevertheless, it really is critical for all providers, including registered dietitians and other nutrition professionals, to recognize and educate about all current evidence. This strongly suggests that delayed food introduction in almost all situations does not prevent food allergies, and instead may actually contribute to increased risk of developing them and or having severe reactions. Current evidence also shows that there is lower prevalence of food allergy in populations who have early introduction of all common food allergens, including peanuts, tree nuts, milk, and egg. It is also important for nutrition professionals to avoid propagating untruths around allergy prevention. For example, it is critical to be clear that breastfeeding has not been proven to reduce allergy. Although breastfeeding, of course, is indisputably recognized to provide optimal nutrition for the first 6 months of life in the great majority of infants, and has been clearly linked to a number of health benefits for both infants and moms, its role in food allergy prevention has not been as clear. Breastfeeding appears to reduce eczema and early childhood wheezing. However, it is important not to state, and certainly not to promise, that it can prevent or delay the onset of food allergy. Similarly, it is really important for all providers to have humility around the complexity of food allergy, as I showed in my favorite slide before, and to realize that diagnosis and management of food allergy may be tricky. For example, tryptase, which is a measurable mast cell mediator, is not always elevated in anaphylaxis, and for multiple reasons, false positive elevated tryptase levels are common. Also, while oral food immunotherapy has gained steam as an option for treating food allergy in recent years, it is pretty clear that it does not represent a cure. Instead, it may confer some safety for severely allergic patients so they can tolerate small amounts of a food without having a life-threatening reaction, but it doesn't cure the allergy. Currently, the diagnosis of food allergy really relies on patient medical history about food exposures and symptoms. As such, when taking a history of food allergy, it is helpful to consider a few characteristics, including the number of suspected occurrences of the allergy, the quantity of suspected food ingested before the reaction happened, the method of food preparation that was used, any relationship of the allergy to exercise, which can also trigger mast cell degranulation of histamine, the duration of suspected allergy symptoms, whether or not the patient has experienced those same symptoms without exposure to the suspected food, as well as the timely proximity of symptoms to exposure. Of course, when considering what type of reaction the patient may be having, as always, it's useful to remember that IgE reactions can occur within 1 minute to 1 hour, while non-IgE reactions generally occur 2 to 24 hours after the exposure. In this slide, I've listed common diagnostic tests for food allergy, including oral food challenges, skin prick tests, and blood testing, all of which are IgE specific, basophil activation tests, patch tests, and elimination diets. Each test is described according to their plausible mechanism, but what the pros and cons column shows is that most are impractical, with highly variable results and variable and even low sensitivity and specificity for the test to actually detect the allergy. So patient history and a good understanding of IgE and non-IgE allergy mechanisms is really critical for diagnosis, rather than relying on any one test to make it for you. Perhaps of most importance is to recognize those tests which are always inappropriate. Generally speaking, many of these involve measurement of food-specific IgG levels, which reflect exposure to foods, not reactions. IgG, in fact, may be an indicator of immune tolerance, not allergy. So while a common misconception is to use IgG testing for food-specific guidance, this is truly a bad practice and one that none of us as nutrition professionals and clinicians should be engaging in. Indeed, use of IgG panels should not be used to diagnose food allergy and should not be endorsed by clinicians or used for dietary guidance. Once a food allergen is identified, current management strategies generally involve avoidance and education around emergency treatment if necessary. In particular, for severe IgE-mediated food allergy, prescription of auto-injector epinephrine may be provided to use in case of anaphylaxis. Most management of food allergy involves personalized diet, which essentially limits food combinations with allergic potential, seeks to replace food allergens with safer foods, and places emphasis on ensuring adequate and optimal nutrition in a manner that will lead to no obvious deficiencies in macronutrients or micronutrients. Much of the management should place emphasis on education regarding food label literacy. And again, it is important to educate appropriately so that patients and clinicians avoid inappropriate food eliminations. There are a number of new recommendations to prevent childhood food allergy that have come about in the past 5 to 7 years that focus on early life dietary interventions. These involve emphasizing the importance of a liberal maternal diet during pregnancy and breastfeeding, as well as the introduction of single complementary foods between 4 and 6 months of life. Currently, guidelines also call for the introduction of allergenic foods, specifically egg, dairy, peanut, tree nuts, fish, and shellfish, during the same 4 to 6 month window. Generally speaking, this introduction should occur after less allergenic foods have been tolerated, with the recognition that delay in their introduction may increase risk of developing allergies. Other good strategies involve the avoidance of tobacco smoke before or after birth and the encouragement of breastfeeding, although again, this is less about the relationship of breastfeeding to allergy prevention and more about its proven benefits, including decreased risk of asthma and infections. In summary, the clinical implications and key takeaways from this talk are as follows. Multiple epidemiological studies have shown a global increase in the prevalence of food allergies. Fortunately, concordant improvements in our current understandings of pathophysiological mechanisms underlying allergy have led to radical changes in clinical approaches in the past decade. Nevertheless, many clinical perceptions persist, which can exacerbate and even accelerate the development of food allergies and may adversely affect patient quality of life. Therefore, it is critical for all clinicians, all nutrition professionals to recognize optimal approaches to diagnosis and management of patients with food allergies, as well as current recommendations and guidelines around their prevention. In this slide, I have provided some references for your further education. For now, thank you so much again for your attention.